The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody, and welcome to the MTMI free webinar brought to you in partnership with Volpara Health. Tonight's presentation is titled, The Role of Mammography Technologist in Cancer Risk Assessment. And this is presented by Lochren, who is a Risk Assessment Clinical Program Manager for Volpara Health. Lee has 20 years of experience in medical imaging and in clinical operations and regulations. She is accomplished in creating systematic screening processes and applying guideline-based medicine to patients at high risk for hereditary cancers, lung cancer, and cardiac events, resulting in prevention and early detection. My name is Susie Coney. I'll be with you this evening. I'm coordinating the meeting. This live webinar is a total of 1 hour long, and a total of 1 continuing education credit, recognized by the ASRT and CAMRT in Canada. We understand that many of you may be new to webinars. We want to calm your fears and make sure that you know that we're here to help. We are able to see when you are logged in. If you are seeing the presentation and hearing my voice, we can also see your name on our roster. But don't worry, we can't see you. We're taking attendance electronically. In order to receive credit, please make sure that all other applications are closed during the presentation. You must be present and attentive for the entire webinar to receive credit. No partial credit can be given. If we find that you are inattentive during the presentation, you will be contacted through the chat box and asked to close any additional windows open on your screen. If for some reason you are disconnected during this evening's presentation, just log back into the webinar in progress. During the presentation, all attendee microphones are muted. If you have any questions or issues, please use the question tools located in your GoToWebinar dashboard. I'll be monitoring these questions to help any webinar problems. At the conclusion and possibly halfway through our webinar this evening, our speaker will answer questions as time allows. To open your webinar tools, click on the orange arrow at the top right of your screen. The question box can be opened by clicking on the drop-down arrow next to the word questions. If you can't find this, click on Raise My Hand icon under the orange arrow and we'll help you. You'll be receiving a link to your certificate in your MTMI account in about 7 days. It's a little bit longer than we normally need to create these certificates, but we've got a big group this evening. So please be patient. You'll get an email once that certificate is created with instructions on how to retrieve it. Following the webinar this evening, a survey will pop up. We strongly encourage your feedback. However, this survey is not tied to your credit. If you are unable to respond, you will still receive your certificate. If you are viewing this webinar in a group, please send me a message through the question or chat box for attendance purposes. Thanks, and Lee, we are all set for you to begin.
Great, thank you so much, Susie.
You bet.
Good evening, everybody. My name is Lee Lochren. I come to you just having sat in your seat about 6 months ago. I'm very new to my company here at Volpara Health, and I come from a relatively small community hospital in upstate New York where I grew up. I basically spent 21 years there working in different roles in medical imaging. In 2017, our hospital and our mammography department chose to incorporate a workflow that included risk assessment. We went on to tackle genetic testing as a point of care service in mammography, and I can talk a little bit about that some more. But then I went on and said, you know what, I'm just going to make myself the director of personalized medicine at my hospital, and everybody loved that idea and loved the principles that we were bringing to the table, so we went ahead and did that a couple of years ago. As a result of that, I started doing some consulting around the country to talk about risk assessment programs And it just got me so excited. And I realized that that was my dream job. I wanted to go around the country and set up risk assessment programs. And Volpara offered me that opportunity. And how could I not? So this is one of my first attempts to do some broad education as far as what a technologist role really is in risk assessment, and how we can work together to create a standard of care that we really believe in based on evidence that we've seen through impacts of patients, real patients with real stories. And my company's chief motivation is to prevent cancer in families, and this ties along with that perfectly. So that's kind of what I want to tackle tonight. Some of you, I really don't believe that any of us are here by accident. And I really think that if you take a look at the content tonight and you take away a few key points, that's going to make a difference in your patients' lives. And hopefully something you hear tonight is going to spark something in your clinical experience in the next few days and lead to saving one of those patients that might have fallen through the cracks. So I'm really glad that you're here with us tonight. You can see this is a patient that was, oh, I just lost my screen. That came to us. Yes, there she is. This is Dawn. This is an article about Dawn. Dawn was a patient who went in for her mammogram, and she was fortunate enough to go to a center that had a comprehensive risk assessment program. And as a part of her routine images, she was offered the opportunity to provide some family history, which determined a Tyrer-Cuzick score for her. We'll get into a little bit about what goes into a Tyrer-Cuzick calculation later on. But for Dawn, this meant her score was at 23.9%. So for her, this had a tremendous impact on her care. She was no longer encouraged. Yep.
We're not seeing your PowerPoint.
Oh. Hold on one second.
Try your webinar tools, show my screen. There it is.
Is it back?
It's back, but not in presentation mode. There we go.
Sorry about that. Okay. I think the little, okay. So Dawn was able to get access to some heightened surveillance that a person who's at high risk needs to have in order to catch breast cancer as early as possible. So because she was 23.9%, she was offered services like a routine screening breast MRI that would accompany her screening mammogram every year, 6 months apart. And because of that, they were able to find through her screening mammogram a stage 1 breast cancer, which led to some very positive outcomes. And at the end of the day, Dawn had a tremendous prognosis and was able to share that with her friends and family. And I have a feeling that I know what center they chose to go to for their mammogram the following year. Dawn's story is not uncommon at this point. In fact, there are a lot of communities popping up on social media and in various places to encourage patients with stories like Dawn to come together. Some of them focus mostly on genetic testing and hereditary cancer risk. Some of them are focusing on breast density. But at the end of the day, all of these communities are coming together with one solid message, which is to provide women with the knowledge that they need to make decisions about their health care and the health care of their family in some cases when we talk about genetic testing, and really support each other through this community. Some of these organizations have representatives that will help healthcare facilities in their efforts to identify these women and get them educated on their risk. So that's all very, very encouraging. And I don't know if we've ever seen all of our medical societies agree on one topic, but in this case, we can see that not only does the NCCN agree, but the ACR, the SBI, even ACOG and the ASBS they're all telling us that they support doing a comprehensive risk assessment on patients between the ages of 25 and 30 years old. So we're sitting here in our mammo departments going, great, that's great. They should totally be doing this in primary care and OBGYN. But the truth of it is, imaging is not serving as a safety net like it should be in this circumstance when we see women when they're 40. But now we're in a position where we are tackling these patients who have never been told what their risk is, and they're presenting to us at 40. So at some point in the future, those measures to tackle risk assessment should and will be happening, I believe, in primary care and OBGYN. But until we get to that point, we're up against it in mammo to say, okay, well, you're here now, you're 40 years old, let's assess your risk now, and hopefully get some answers for you, and in some cases for the rest of your family. And then in future generations, those members will be able to have access to care at an earlier age and prevent cancers before they become an issue. And we're starting to see growing advocacy for this type of care all over the country. If you'll recall, a couple of years ago, we went through this with breast density laws. Women have a right to know in some states that they have dense breasts. We have dense breast legislation on the books. It can vary from state to state on how we notify women, but we've recognized at this point that we have an obligation to notify them so that they can become advocates for their care. And we're starting to see that happen through grassroots efforts with genetic testing as well. Genetic testing used to be seen as a tool primarily from oncology to diagnose women with hereditary cancers after they've already been diagnosed with breast cancers. I went to a conference a couple of months ago with a lot of breast surgeons, and they told me at the conference, if you're doing genetic testing at the point where a woman has already been diagnosed with breast cancer, then it's kind of like passing wind in a hurricane. It really doesn't mean that much at that point. If we can tackle this issue when women are between 25 and 30, if we can get to the men that are at high risk at those ages, we can really start to move the goalposts up and to start to affect generations of care. And I do think that we'll get there. Like I said, we're already up against it in mammo. We already know that only about 60% of women are coming in for their mammo to begin with. We had a lot of hurdles that we needed to overcome during COVID, and now we're starting to see a surge of COVID in different areas of the country, so I'm not sure if that's going to lead to another dip in patients' compliance, but patients don't need much of an excuse when it comes to not going to their mammo. Oh, it's raining outside. I think I'm going to cancel my mammo. And we see that every day. We also know that even when we talk about genetics, that 90% of women who are of hereditary risk are not yet identified. Women have a lot of trouble when it comes to getting genetic testing. A lot of systems, even well-meaning systems, are inadvertently putting up barriers to care when it comes to getting genetic tests done. We can talk more about that later. Might be a little controversial, but I'm excited about it.
Lee, we lost you there. Lee, if you can hear me, will you close your camera, please?
Dismally, that less than 2% of women that have been identified at high risk are complying with their advanced services like breast MRI and genetic testing. And 15%, there's been a 15% increase in compliance that has been shown when all we have to do is talk to women about their risk. So every day we have patients that are coming into our centers. We know they're high risk. We're letting them go. There's an opportunity there to connect with the patient, make sure that they understand their risk, and have an increased chance of getting them to comply with those recommendations if we just help them understand what that means for them. And technologists, I mean, it kind of all starts with us. So I was a technologist for a very long time. Your patient, hopefully in a best case scenario, has an opportunity to fill out a family history at home. That's a relatively new thing. We used to have to wait until the patient came in, and we have very confined amounts of times to pressure the patient into giving us a family history. So now we have an opportunity to send that survey home through the patient, sometimes through their electronic chart. We've seen a large uptake in adaptation to the electronic chart lately, mainly because of COVID. So we can send them a survey that they can take their time and really fill out comprehensively at home. So a patient doesn't need to be under pressure to remember when Aunt Sarah had her breast cancer, or if Uncle Phil's had colon cancer or pancreatic cancer. There's an opportunity there to really take your time, do a good job with your family history. A lot of us now have EMRs that can collect that family history at any point of entry into the healthcare system and have that be available through a shared point. So if a patient goes in and gives a family history to an OBGYN doctor, that history is then available to the technologist when they're looking through to see if their patient's going to be high risk or not. Not in all cases, but in the best cases. So a technologist is under a lot of pressure. I totally get it. You have a lot of pressure when it comes to image quality. You're being measured on productivity. There's so many things to take into account when you're there for that brief time with that patient encounter. But a technologist, as much thought as we put into positioning and making sure everything looks just right, we need to put that same thought into collecting an accurate family history and an accurate patient history. And we'll talk about the different data points that go into calculating an accurate risk score for that patient. And I'll say it again later, probably, because I can't stop saying it, but the difference between a patient getting that care that they need as a high-risk patient, the access to the breast MRIs and sometimes ultrasounds and CESM, that the difference between getting that care and not can sometimes be just getting an accurate history of when the age of menarche started. So just something to really think about when you're keying in some of that history from the patient. It's incredibly important to be as accurate as possible. And of course, all of that information then goes to the radiologist and into the report. So we want to make sure that the information that we're putting into the report is accurate and that the referring physicians have confidence in the information that we're giving them. And unfortunately, we can't get out of this by saying it's out of our scope of practice, because it is well within our scope of practice. Everybody signs up for to support the AART standard of ethics when you become a radiologic technologist. And there are a couple of bullet points in the ethics standards that really stand out as far as collecting an accurate family history. We have obligations to act in the best interest of the patient, including taking an accurate history. We have an obligation to obtain information for the doctor to aid in diagnosis, and of course to protect the patient's right to quality care. That all falls within what we're trying to accomplish with getting an accurate family history. And I want to say that I love this slide because I've never seen a better visual that was so literal before. And this was designed by the scientists that came up with a cancer risk assessment tool. And it really gives you an accurate depiction of the types of risk assessment, the types of factors that would affect a risk assessment. So you can see there the density, the family history, instances of benign disease, and I can't see behind my screen, OBGYN factors that all play into a valid risk assessment. So as far as density goes, density affects a large portion of the population and can present a relatively significant risk factor as far as a score goes. Family history would affect a smaller population, but the family history that you give can have a dramatic impact on a risk assessment score. Benign diagnosis, same thing, very small percentage of the population, but can have a huge impact on a risk assessment score. And those OBGYN factors will affect a lot of patients, but have a smaller impact. And I'll go into details a little bit on that. So there are so many risk factors that are incorporated into these risk models. And I know that, as techs, we're sitting there going, I can't imagine this intake taking any longer than it already does. How many questions do we need to ask this patient in order to assess their history properly? We used to be confined to what would fit on an 8x10 sheet of paper. And now, fortunately, we're in a position to really broaden that out a little bit, push those surveys out in advance to those patients, and collect a more robust family history that we can then leverage to designate whether or not a patient is at high risk or not. So there are a lot of different models. There's a lot of confusion about the models, but we made basically a too long didn't read summary of what the models will get you. So based on the goals of your program, these are the model considerations that you would make, what you want to do, what you're trying to accomplish. So if the goal of your program is to designate patients at high risk, and you want to provide those women with an opportunity to get a screening breast MRI, or to take a look at their density a little bit further, knowing that mammography is not enough when it comes to assessing a patient with dense breasts, we're going to be looking at the Tyrer-Cuzick model and a system to identify the density in those patients. A Tyrer-Cuzick score of over 20% would indicate a high-risk status. 15 to 19.9% would be a moderate risk, and those come with different types of recommendations for each. Patients that are going to be amenable to genetic testing so that we can see if they have hereditary cancer syndromes. If we're going to be talking about that service line, then we're going to want to ask questions that are geared to NCCN guidelines and BRCA Pro guidelines. And those can be done together or separately. Some places will do Tyrer-Cuzick in mammo and NCCN in advanced services like breast surgery or genetics. But some places will do them together, and we'll talk about that. And then we have GALE. The GALE model predominantly looks at services like chemo prevention for patients, and will identify that portion of the population that would, the risk would be mitigated using chemo prevention. But the GALE model is usually not so much used in imaging anymore, but we usually see this in more of a high-risk clinic setting. So maybe this is a bit controversial. I don't think so, but this is my my plea for using both in your imaging center. I would ask that imaging consider their standard of care and expand that to incorporate Tyrer-Cuzick services, Tyrer-Cuzick model, and NCCN guidelines. And for a couple of reasons. Tyrer-Cuzick is female focused, so think about the few men that you have coming into your center. All of our questions are related to breast and ovarian cancer, but that patient could easily have a history of pancreatic and prostate cancer that would lead that patient to falling through the cracks as far as being identified for genetic testing. We have our breast cancer patients, our affected patients that have no Tyrer-Cuzick score because the risk of breast cancer is here. So those patients often don't get genetic testing done until after their cancer diagnosis. And we talked about, a little bit about why that was problematic. We have an opportunity to address that patient's cancer risk far earlier on. So we should take advantage of that. And then we have a young woman, say at the age of 35, with a diagnosis of hyperplasia. You know, in this situation, those benign breast diseases can have a very high risk to go along with it. She wouldn't be eligible for genetic testing, and sometimes Tyrer-Cuzick can overestimate the risk on patients with benign diseases. All right, here's my big plea for why we should do both. This is a patient who came into an imaging center in 2019. She had no family history at the time. She had a Tyrer-Cuzick score that was calculated to be at 6.4%. This patient would not be qualifying for genetic testing under NCCN. She would not be qualifying for breast MRIs. And she even was an ACR too. So we told her, we'll see you next year. Hopefully she's compliant with that, fingers crossed. So in 2020, this patient came back. And now, because we're doing NCCN guidelines in conjunction with Tyrer-Cuzick, she identifies now a history of a grandmother with pancreatic cancer, a maternal uncle with pancreatic cancer. So that's 2 instances on one side of the family. Her Tyrer-Cuzick score is a little bit lower this year. So again, her images were completely negative. But because she had flagged under those NCCN guidelines, we were able to offer her genetic testing at that point. And lo and behold, she turns out to go from one of our smallest risks of breast cancer and would be otherwise categorized in population health standards to one of our highest risks now. And not only does she have a 45 to 55% chance of breast cancer through her BRCA2 diagnosis, but now she's at risk for developing other types of cancers. So she's at risk for ovarian cancers, a second breast cancer, and even a risk of pancreatic cancer that is above the general population. So she needs changes to her medical management that includes surveillance for those different types of cancers. She came in for a screening breast MRI and had some enhancements or some lights that showed up and went on to have a prophylactic mastectomy as a result. This patient, though, if you think about it, and this is one of the reasons why I get really passionate about this topic, this patient would have gone completely undetected at all points in the system. There was nobody asking about her pancreatic family history in the OBGYN office. Her primary care was probably just excited that she didn't need a breast MRI or any additional services and that they were just going to sign her up for her mammo next year, but she was sitting there as a ticking time bomb. And I needed these additional services. All right, so this is a patient. Her name is Mary, and we know that she is 50 years old. She, with that age, you can calculate a Tyrer-Cuzick score knowing only that a patient is female and what their age is. So given those factors that we know about her, we can calculate that her Tyrer-Cuzick lifetime risk is going to be about 8.1%. And that is at general population risk. I would not say, I would veer away from saying she's low risk to saying that she's at population risk, because I would never want to discourage a woman from not getting a mammogram. But she's got some recommendations with that come from the ACR now, and that includes the very basic digital breast tomography starting at age 40 in most cases, with no advanced history. So let's say we take Mary and now we do a little bit more of a thorough job in getting her history in. So we know that she's a BI-RADS-C. Maybe we got that from last year's mammo. Maybe we're getting it from this year's. We know that her age of menarche began at 10 years old and that we have her height and weight. We also know that her first live birth was at 30 and that she's premenopausal. And this is all stuff taken from a very typical MQSA mammo history intake. So now we see that this changes Mary's story a little bit. So now she's at intermediate risk for Tyrer-Cuzick. She's at 15.2%. With that comes some recommendations that may be a little bit more lightly worded. And we suggest that she may want to get an ultrasound. She may want to get an MRI without contrast. And those are supported by the ACR. The NCCN doesn't really offer anything different for our moderate risk patients. She, at this point, is not recommended to get an MRI. That's not on the ACR's agenda for intermediate patients. But okay, so let's say that we have gone ahead and followed Lee's recommendation and we turned on NCCN criteria in conjunction with the other one. So now we get Mary, who's, she's 50 years old. She's still got C breasts. She still had her age of menarche at 10. She's 5'6", 180, got her first live birth at 30. She's premenopausal, but oh my gosh, we're taking a family history now. And she has a paternal aunt with a breast cancer diagnosis. This changes her entire outcome, just knowing that one piece of information. It sounds so trivial, and it's something that can definitely be rushed over when we're in a hurry and we're trying to get a family history, and you know, the patient's running late, we're running late, we have to go to lunch, we have to get back to this and that. Totally could be overlooked. So this patient now, she's gone from an average risk to having a high risk of breast cancer with a Tyrosine score of 21.9%. So you can see the ACR recommends some different types of activities for Mary now. She needs a mammo. She needs maybe an ultrasound. She definitely needs a screening MRI. She should not be in the same category as our population risk patients. She's at high risk. She needs to understand this so that she can make the right decisions for her in order to deal with this properly. So it's amazing what that one piece of family history can do to a score. Okay, so now we take Mary and we collect all of the information. We did a great job. We asked about family history. Now she tells us that she has a paternal aunt with an age of 35 as being when she got breast cancer. What does that do to Mary? Let me tell you what it does to Mary. It's such a small, again, it's a small detail that we collect in our family history, but can totally change outcomes. So now we have Mary, who is, again, at high risk. Her risk has actually gone up a little bit. Her Tyrosine is now 22.3. But the most important thing here is that now that we know that age of onset, young cancers is something that we're looking for in those NCCN guidelines. So we know that she qualifies for genetic testing. Luckily, we've gone from the age of memory-based medicine to software that provides us with clinical decision support. There'd be no way that we could memorize all of the ever-changing NCCN guidelines, and I get that, and I would never ask anybody to do that. But we don't have to, because now there's software that supports that clinical decision support. So we can put in all of Mary's risk factors. She can put them in from home. We can validate those, and then the computer can tell us whether or not she met that criteria. There are advances now in genetics so that whether we choose to send that patient off to a referral for genetics, we can do that. But we can also consider in today's day and age to offer what is considered to be point of care genetics. So we're really looking to identify women with genetic mutations as part of our program goals. We're able to do that using software. So in Mary's case, yes, she qualifies for genetic testing. And just like that patient that I showed you earlier, that can mean the difference between a relatively moderate to high risk to, okay, we need to see a breast surgeon kind of risk. So if Mary is gene positive and it's not just about BRCA anymore, her management plan will completely change to address some risk mitigation strategies. This has a huge impact on Mary's family, because what if Mary has daughters, Mary has a son, sons can be carriers of the BRCA gene. What does that mean for them and their future generations? So it ties back to that whole family story. And it's what did I have under here? Oh, it's not just about BRCA anymore. Sorry, I can't see under my panel. It's not just about BRCA anymore. Now we're encountering situations where we can do panel testing to test for a variety of syndromes, because a lot of the syndromes and the cancers in the hereditary space overlap. So we're looking at not just BRCA1 and BRCA2, but we're looking at different types of genetic mutations that would also place Mary and her family at a considerable higher risk for breast cancer. So when we start to look at, okay, how can we, we're running these risk models on patients. Now we're encountering situations where maybe our referring providers are calling us and saying, I don't understand how my patient could be at high risk. Can you help me explain? In this case, we are able to offer patients sites that chance to really break down lifetime risk. So this isn't Mary's situation necessarily, but a different type of patient, but you can see how everything kind of layers in and starts to change the risk factors. So we have people with age, like I said, we can do a risk score based on knowing that she's female and knowing her age. And in that case, this patient was 8.16% knowing that. If we put in information about her race and ethnicity, particularly if she has an Ashkenazi Jewish heritage, we can place that factor in, and that could push up or down. Any of these factors can be either protective or they can be harmful in their effect on the risk score. So we have the patient's medical history drove the score up just a touch, and that was probably because she had a biopsy with an unknown outcome, and the thinking in the model being that if she had a biopsy, that meant that there was probably a suspicious finding. So because we don't know the outcome, it does push it up a little bit. And then knowing that family history will start to really affect the risk score. And then knowing her breast density, obviously we talked about that first pillar, that's going to really determine whether or not she was at high risk. I'm gonna pause at this point to ask if there are any questions, because I feel like we covered a lot in that segment.
Lee, let me read you a couple questions because I have a whole lot of other problems going in here, so you don't have to root through them. Is there a website link doctors can go to get info on TC?
So I don't know of a link. There are a couple of different ways that you can get a TC calculation. You can get software, you can have it embedded in your EMR, or you can go to a free calculator online. It's a bit tedious. You would have to manually enter all of the information. There's a lot of information on Tyrer-Cuzick out there, but I would be happy to provide some detailed information if you want to send me your email address.
And I see that we can see your email address here.
Yes.
So questions can come directly to you?
Yep, and we can reach out and talk about specific needs.
Okay. Another question before we move on. How do we do risk assessment in this population as a mammotech, or is it the doctor's responsibility?
So it's a really good question that comes down to scope. I would say that our responsibility as mammotechs is to provide all of the data points necessary in order to perform the calculation. Different sites will have different ways, different triggers for actually performing the calculation. Most sites will have the techs hitting, calculate button and then providing that information to the radiologist. Sometimes it will go automatically into their report, and sometimes the radiologists want to dictate it into the report. Some systems will enable you to not only drop the information into the radiology report regarding score, but also the factors that led to that score as well, if they want that as part of their report.
Okay, let me ask you one more before we move on.
Okay.
MagView has a risk calculator in their programs. Does Volpara have something similar?
Yep. All of the mammo information systems will have some type of risk calculator built in. Volpara has a couple of different ways that you can get the risk calculator. You can use the patient hub information system. You can have it incorporated right into your Epic workflow, which is probably the most popular because there's little outside intervention that you have to perform. And we also have it available in a cloud situation if you don't want it integrated.
Okay, great. Why don't we see about finishing your slides, and then we can look at some more questions.
Great. Okay. So there are a lot of common questions that we get because obviously this can be kind of a confusing topic. A lot of centers are just beginning their journey on the risk pathway. It's not an easy journey. Nobody ever said it was, but you know, I think you've seen the impact that this can have on patients and outcomes. So it is important. I think that there's an urgency to make it as seamlessly integrated as possible to get that information to as many patients as we can. You know, hopefully some software solutions are along in that journey, or else it can be a really manual, time-consuming process. So in this section, I want to talk about a couple of different things. What happens if data is missing? We talk about competing mortality, OBGYN risk factors, asking about unaffected individuals in trying to assess a score, and a little bit about volumetric breast density and how it impacts a thyrocusic score. We can touch on why patients' risk could be so high and a little bit about benign pathology. So this should look familiar to those of you that have already started down this path of trying to incorporate Tyrocusic into your workflow. On its face, the request to put Tyrocusic into a report seems really benign and easy to pull off. But I will tell you that it's not as easy as it seems, and there's some thought that you need to put into your risk program before you just go plopping a number into a report. And we can have that conversation if you want, you can call me. But I would encourage you to take some time and do it thoughtfully and invite your top referrers to that conversation before you tackle that. You can certainly run a Tyrocusic score without all of the factors, but you will get a much more accurate picture of risk if you include as many factors as you can. And you know, while we do want to capture all of the women into that high risk bucket that meet that criteria, conversely, we don't want to put women in there that don't belong. So we need to make sure that we're doing a good job in accurately reflecting her risk. And I will tell you that one of the common things that I see when I go to sites and they're just starting to do this is they'll skip questions because it doesn't pertain to the patient. If it doesn't pertain to the patient, if they're not on hormone replacements, hit no. And no will give you a more accurate score than no answer, because no answer will in some cases lead to a risk score that's inaccurately calculated. So yes answers are just as important as no answers in those cases. All right, so in the competing mortality subject, I am very much in the mammo world. We have a see one, do one, teach one kind of mentality, and I will be truthful with you in saying that this is my teach one. So when we think of Tyrocusic, we think in terms of 10-year risk and lifetime risk. And the statisticians have dictated to us that a lifetime is 85 years old. So over the course of a woman's 85 years, from the time she starts mammo until she passes away, she has a chance of passing away from breast cancer. Yes, we assess that risk. But she also has a chance of getting hit by a bus, or in some cases, developing a circulatory disease that's really common. There are a lot of ways that people can pass away. So we need to be able to reflect that in our risk scores in a way that's meaningful. So you'll hear something like, you know, we need to turn competing mortalities on. So what that means is if we turn competing mortalities on, and we can either have competing mortalities turned on or off, but if we turn them on, that means that a patient will have a lower chance of being categorized as high risk. So there's in your population of patients, if you have competing mortalities turned on, about 8 to 9% of your patients will be determined to be at high risk by Tyrer-Cuzick. And that's based on, you know, I think we do about 2 million risk assessments a year in my company. So, but if we leave that turned off, so we're not taking into consideration that women could be dying of other things, then we're going to see a population of about 11 to 13% of women who are going to be put into that high risk bucket using Tyrer-Cuzick. And I think this is important because a lot of the pushback that we hear about Tyrer-Cuzick is that it over-identifies women. And if you're finding that that is a pushback that you're receiving, I would highly consider turning competing mortalities on so that it more accurately reflects risk. Hopefully I did a good job of explaining that. All right, how important are all of those OBGYN factors in a Tyrer-Cuzick score? If you take each factor individually, maybe not much of a difference in the Tyrer-Cuzick score. Let's just take age of menarche to start with. So you can see that if a patient starts at 10 years old, that comes with an inherent risk of 13%. If she starts at 17 years old, that risk starts to go down to 9.3%. And the same with other factors, you know, age of first live birth, that can kick it up or bring it down a couple of notches. But the important thing to know about OBGYN factors is that they're cumulative. So this is going to have a weighted impact on the score. And the other thing to note is that height and weight is not just about a patient's height and weight. It also incorporates breast density factors in there as well that need to be considered. And if we're talking do one, see one, teach one, see one, teach one, do one, this is my, I don't know, I'm just starting to learn about this stuff. So in the imaging world, we don't focus a lot on pedigrees. Pedigrees are traditionally tools that are used to help genetic counselors talk about risk with patients and help them to determine whether or not genetic testing is right for them. So you'll see that this patient in the first case, this patient down here is 40 years old. If we only know that she has a paternal aunt with breast cancer at age 35 and a paternal grandmother with ovarian cancer, but we don't know the age, we can see that patient has a 15% chance of a mutation risk. And if we keep adding aunts on to that side of the family that are unaffected, that's not going to change that patient's risk score. But if you see in case number 2, now we've got a patient that has breast cancer in her aunt, and we know the age of her other aunts. This is where it gets a little confusing, but hang in with me. If her other aunts are age 90 and haven't developed breast cancer, then that brings the patient's chance of developing a mutation way down to 5% at age 40. In situation 3, you can see that because that breast cancer and ovarian cancer on the mom's side of the family are in the same bloodline, they're working together, they're collaborating to increase or decrease risk. So we know that in this case, in number 3, if the mother of the patient hasn't developed breast cancer, she's 90 years old, she's gone her life without getting it, there's an interruption in the inheritance for a possible gene mutation. So that brings the patient's risk way, way, way down. I know we're super in the weeds on this, but hang in with me. the age in situation number 4, we see that the patient has an aunt still with breast cancer, but we don't know her age. That brings the patient's risk way, way down. I think you're starting to see the reason why we rely so much on software now to do this for us. But I just want you to know the thought process kind of behind the software. So in the family history where we take the patient and we say, okay, but we know that she has some Ashkenazi Jewish history in her family, that brings her mutation risk way, way up because there's such a high risk of genetic mutations in that family history that's been documented. So this patient would be flagged automatically for genetic testing. Whew, that was a tough one. Pedigrees are tough. All right, so volumetric breast density. You guys know that we have categories A, B, C, and D, right? But I'm sure that you've realized that even within those categories, those BI-RADS categories, that they can look very, very different. And this is one of the reasons why sites get a little bit hung up when it comes to assessing breast density visually. It can be a little deceiving. So in this case, these are 4 different pictures. I promise you there's a method to the madness here. There are 4 different pictures of different types of categories. There you can have what they call a low C with a lower volumetric density. You can have a middle C and then a high C. And those outcomes can be drastically different for different patients. So in this case, we can see that if you're in the Taracusic calculator, you have an option in the beginning to choose from the BI-RADS category, A, B, C, or D. In Taracusic 8, they've included a volumetric density input. So you can include the volumetric density percentage that's measured and defined. So the easiest way that I can think of to describe this is if your child comes to you and says, I feel sick, and you put your hand on their forehead, it feels warm. Does it feel warm like fever warm? Does it feel cool? It's a little bit subjective, right? So if you then go on to take your child's temperature, now you know definitively whether or not that child has a fever based on the degrees that are showing up on the thermometer. So volumetric breast density works in very much the same way. Not that we as techs have a say over whether our institution chooses to use categories or volumetric density, but just to let you know that input that's there, that's what it's for. So it takes a more precise reading of that picture, that volumetric breast density percentage, and puts that into the calculator. And as we talked about, like sometimes it's just a little bit that tips that patient in one direction or the other. So this is one of those other things that could tip it in one direction or the other. So in some cases, it could decrease a woman or increase, especially when we get into those C's and D's, the BI-RADS category percentage will underestimate that risk. But if we use the VBD, it will more accurately assess the risk for that patient. Oh, that's a lot. Okay. Samantha. I had the opportunity to make up these names, so I made up Samantha today. Samantha is a 55-year-old patient. She is going through menopause at the age of 52. She has a mother with breast cancer at age 60, and she's got a category C breast density, but we know that she has a volumetric breast density of 14.9%. So if you take this patient and you look at her using both, so if we use the C category, she's got a lifetime risk of 16.8%. That's going into her Taracusic calculator, that's going into the mammo report, that's going to say that she's moderate risk and that she needs to be assessed at that level. So not quite population risk, but not quite high risk either. The insurance isn't going to cover that high risk breast MRI. They say she doesn't need it. Okay, so if you take that same patient, Samantha, and you say, okay, we're going to use volumetric breast density to look at her, and maybe she's a dense C, one of those high Cs, you're going to see her lifetime risk go up significantly in this case to push her over the threshold for high risk. So now she's at 22.6%. She's got access to all of the things that she needs in order to make those decisions about her care going forward as a high risk patient. So that's good. I haven't heard this so much from techs, but I hear this from referring providers. How could my patient's risk be so high? You know, oftentimes they're just looking at that family history and anecdotally assessing her risk based on the family history. So I just wanted to give you guys a couple of reasons of why a patient's risk could be as high. The two obvious ones are those BRCA gene patients. So those aren't going to be as many patients, but again, those risks are super high for those patients. And then you have a couple of other benign pathologies there that would also lead to an increased risk, and a questionable biopsy. Again, we talked about a biopsy probably indicated some suspicious findings and therefore would affect the risk score a little bit. And I am by no means the expert on this, but if you want to have a conversation about how to categorize specific pathology from a limited drop-down menu, I have the doctor for you to talk to, and you should let me know. But Dr. Hughes is one of the founders of Risk Application, and he went through and tried to map the benign diseases to a category that would indicate an accurate risk score. And, you know, in most cases, these would be considered high-risk patients. All right.
Okay, Lee, let's just take a couple minutes. There's some good questions here for you.
Okay.
And if any of you folks need to leave, that's fine. You know, you've put in your hour, but let's see what we can come up with here. What about a transgender patient? A lot of the questions on the TC and Gale models do not apply. Are the risk model accurate and creating a risk score?
I would say in instances where you have a transgendered patient, you would want to consider falling back to the NCCN guidelines that rely on family history to indicate whether or not genetic testing would be appropriate for that patient. But the Tyrer-Cuzick model, you're right, is primarily focused on female at birth patients.
Okay, here's another good one. If there is a prior biopsy but the result unknown, is it important to hit the result unknown button, or better to leave that as the first choice, which is no biopsy?
I would definitely hit unknown result, and then consider if you have a mechanism once you get the result to go in and recalculate that risk score, because that can mean the difference between an unknown result just kicking it up a little bit, or a known result, maybe, you know, especially if it includes benign pathology, increasing that score tremendously and really affecting the care of that patient.
Okay. And how important is it to document cousins or great grandparents or great aunt and uncles?
Yeah, it really depends on the goals of your program. You know, I feel like in most cases you have to balance the program goals with how much time you're able to spend with that patient. But certainly with the bringing in the ability to push out patient questionnaires in advance and letting them take the time to collect that history, you can get more of that extended family in there. And the more detailed that we have, you know, the more accurate the score.
Okay, well, I think we've used up our time, Lee. We thank you very much for your presentation this evening, and thank you for putting your email address up there. You may get some questions down the line.
Oh, that'd be great.
Great. So everyone, as you exit the webinar this evening, please take just a moment to answer those survey questions. and give us a week or so to gather those certificates for you. But we thank you. We thank Lee, and we thank you all for joining us this evening.
Thank you. Have a great night.
All right. Thanks. Good night.
Bye-bye.